Yeah. So this is a slight modification of Dr. Geber-Shariat's, Dr. Yamane's double needle fixation. This is an animation which shows what Dr. Yamane does is the double needle technique, where he engages both the haptics internally, and then these haptics are brought out under the conjunctival space simultaneously. When you practice this technique during the learning curve, there are always chances that this double needle technique may not come handy and the lens may slip. And so we decided a slight modification where we engage the first haptic like what Dr. Prabhu just showed us. So this is the technique of Dr. Shin Yamane, bilateral simultaneous externalization of the haptics. So when Dr. Yamane does this technique, this is how it looks. And when we do it, this is how it is going to look. I will just show you. So we have also engaged the haptics simultaneously in the 26 gauge needle. And while we try to bring the haptics out, the lens slips inside. And if it happens with one haptic is fine, but if it happens with both the haptics, then there is always a risk of an anterior segment surgeon may have to call a retina surgeon on table. So what we decided is that we can at least flange one haptic first outside and then only go ahead with the second haptic. Because our country we don't get 30 gauge needles, so the snug fit of the haptic is not possible. So we use 26 or 27 gauge needles, McPherson forceps for the scleral tunnel trailing haptic. So this is the video which shows our technique of simple haptic fixation. Anterior vitrectomy is carried out after this sublapsarial cataract was removed. Chamber is filled with viscoelastic. This is a marker given by Dr. Amar Agarwal for blue scleral fixation IOL. It also allows us to track the path of the needle, so it at least can go oblique and make a small scleral copy pixel. Is threaded into the needle. And once the first haptic is externalized, then we are going to proceed with the other one. This technique can be especially useful for beginners so that they don't land up with complete dislocation of lens during scleral fixation of the eye. The main port itself, we engage the haptic and then it is externalized and then flanged using the cautery. So that's how this technique works. Now I will proceed on to my next talk about complications of scleral fixated IOL. Just allow me a minute. Where is the video?
Just. Yeah.
Yes. Yeah.
Dr. Aditya, can I have a question meanwhile as you're opening the next presentation?
Aditya?
Dr. Aditya, can you hear us? Yes, he can't hear us as well.
Dr. Mandar, are you seeing the video?
We can't
No,
see the video,
no.
doctor.
No.
Just pause the video. Then start
First,
sharing.
let's start this.
Pause the video, please.
Yes.
And go to this.
Doctor, can you hear us, Dr. Aditya?
Maybe maximize this. Pause.
Dr. Mandar, I guess Dr. Aditya can't hear us as well.
Aditya, can you hear us?
All right.
He started, yeah.
I hope, Mandar, this video is visible or not?
Yes, yes, yes.
Dr. Aditya, you're on mute. If you could
Dr.
unmute.
Mandar, are you able to see the screen now?
Yes, yes, we can see the screen. Please go ahead.
Hello. हाँ येता है एक बार दिसते
Okay. All right. So this is a presentation about complications of the scleral fixated IOL. This is a patient who is post RK. So we are doing the Yamaha scleral fixated IOL in this case. So first needle, both the needles are inside the vitreous cavity right now. The haptics are well engaged, and I am quite confident here that it is going to go smooth. But then, as I was retracting the needle, I realized that the lens is going somewhere else. It was a clear indication that probably the haptic has started to slip. And so I was actually very careful in catching it as soon as it comes out, but it didn't come out at all. And there was some bleeding already in the conjunctival space, so that made things a little worse. Then I kept on holding on to the haptic, brought the other haptic into the anterior chamber, and then we repeat the procedure. So here the role of assistant is very important. He's holding on to the haptic on the other side. So as soon as the haptic is out, we flange this, and then that's the end of the surgery. So the same thing is repeated on the other end. So this is a way to manage intraoperatively slipped haptic. The lens is now well centered. Same thing can be done with the help of a trocar, just in case you are not confident with the needle technique. This is a patient who had a drop nucleus, so that's why you see a small opening on the superior temporal side for the fragment opening. So luckily, at least one haptic is still outside. This was also almost going in completely, but luckily we could rescue that. And we make a slightly bigger flange. On the other side, the because there is conjunctival chemosis, I decided to open the conjunctiva and put a trocar. And through the sclerotomy, again we use our interarterial forceps, engage the tip of the haptic in the forceps itself, take the trocar out, and then the haptic can be brought out and then flanged. Conjunctiva then has to be cauterized or sutured depending on how big the opening is. But again, the lens comes in stable. And this is another video where the first haptic has been flanged now. Now we are moving ahead with the second one. And unfortunately, the lens is twisted and we don't know exactly what is happening with the first haptic, but it is almost certain that it is also dislodged. So we bring that haptic out, but we can't reintroduce it into the needle, and so we have to cut this flange. And the lens did get completely 180 degrees internal rotation, but this is a non-aspheric IOL, so it doesn't really matter how the lens is positioned in the sclera. So once again, the flanges are made and the lens goes back. So that's about the haptic story of Yamani's scleral fixated IOLs. Thank you, Dr. Mandar, for inviting me here on this.
Thank you, Aditya, for sharing your